Hello? Hello? Yeah. Hello.
Oh, hello.
So
Hello.
sorry, I don't think I
Hey
can
everyone, good afternoon.
Good afternoon.
change my
Just put in
audio
the chat that I
settings.
couldn't unmute myself, but that is no longer true.
Yeah, I think I'm able to speak as well now.
Okay, perfect. I don't think I have access to a camera, it doesn't look like. And I'm not sure if you're sharing anything on the screen, but
Hello?
Hey, Bonnie, we can hear you.
Hello?
Oh, Bonnie might not be able to hear us. Can anyone hear me?
Yeah,
I can
we
hear
can.
you,
Hello?
Mariana.
Okay,
Yeah.
good. I can hear you also, Corinne.
Okay, great.
And
Jimenez and
Renee.
Jimenez, nice.
I know. I'm like, are you cousin? Hey.
We're all
Hello?
cousins, right? Yeah.
Right.
Oh no.
Let me let Bonnie know we can hear her, but she can't
This
hear
is
us.
not
Okay.
good.
And I'm
One
not sure if
second.
there's anything being shared. It just says DC Health on the screen right now.
Right.
So
I also see just DC Health at the moment.
okay.
Did you all get the opportunity to put in the password when you logged in, or were you all just
I didn't
like
need to. I just had to register again. I'd registered a few weeks ago, but it made me re-register when I just joined a moment ago.
okay?
I was able to put in the password.
And I just clicked on the link.
Oh, nice.
Okay. Yes, so as soon as everyone signs in, everyone will be on mute, but I have the ability to unmute everyone, and I think at the beginning it says if you want to be unmuted, you can raise your hand, but I'll just unlock that for everyone. I will be sharing my screen. Let me see if I can pull it up now.
Okay. And Vinay, I know you'll be running the demo portion and we'll jump to your screen share. So just want to make sure you have that button. Oh, it just popped
I
up for me. Okay.
I don't see that one. I see it now. I think.
Okay.
Yeah.
Yes,
Yeah, I think there's like a delay on the tools and bells and whistles.
I granted Corinne, Samia, and Vinay panelists, I guess, functionality, so that you should be able to share your screen if you have the share at the bottom.
Okay.
Yeah. You see it. Thank you.
Okay,
Thanks.
I'm going to put this in presentation mode. Is everyone seeing the slide in presentation mode, or is it still in just the PowerPoint?
Don't see anything yet, actually, but I think, as Corinne said, there's a delay.
Yeah, same. I don't think it's popped up yet.
Hmm. Hmm. Mhm. How about now? Is everyone seeing the presentation?
Yeah.
Yep.
Mhm. Hello, everyone. Let me make sure. Welcome, everyone. Thank you for coming. I'm just going to give everyone a couple minutes to join. Hello, everyone. Welcome, everyone. We're just gonna give some people time to join. I know that we're transitioning from Zoom to WebEx. So I wanted to give people time to just sign in. We'll just give a couple more minutes before we get started. Okay, I see people, and I believe we are almost at this threshold, so we can start. Hello, everyone. Welcome to our, oh, I don't know what this is. No, it's correct, but welcome to our March Learning Collaborative. Today, we will be going over programmatic updates from the Chronic Disease Division team. We will also have a presentation from our data analyst regarding medication adherence versus hypertension control. We have some speakers to walk us through top health analytics, medication adherence prediction reports, and a report demo. As always, if you have the opportunity, we would love to have you on video. Introduce yourself in the chat with your name, title, and organization. And today's icebreaker would be, what is your favorite sign that spring has arrived? For me, it's switching my big puffy or wool coat for something much lighter. That is my favorite sign that spring is coming. Unfortunately, we had a little bit of a tease for that last week, and this week has just turned it all around because the day was very cold. But if you can all just give us some of your favorite signs in the chat, that would be greatly appreciated. And we wanted to remind everyone of what our Learning Collaborative structure is. We have capacity building calls, we have work plan report outs. We also, in this Learning Collaborative, have biannual in-person strategic planning sessions. We just had our in-person Learning Collaborative last month, February. Thank you all who registered and were able to attend in person. We really appreciate all your insight and participation in the discussions had that day. So in the current cycle that we're in right now, today, like I mentioned earlier, we'll be having some medication adherence prediction reports and have some slides and data surrounding that. Next month will be our work plan report out session. So we'll have some of our grant funded partners report out on their current initiatives. we will follow up with those our confirmed health system partners and who will be reporting out next month, and I will follow up with an agenda closer to the date. Our May topic for May 20th is to be determined still, and again, we'll update you as we have more information. Now I'm going to pass it over to our data analyst. I'm going to mute myself, and Samia, please unmute yourself and let me know if you're able to get audio. Apologies again, everyone, for this new system. We're all kind of trying to work through the kinks and the functionalities and all of it.
Good afternoon, everyone. My name is Soumya Rajmohan, and I'm the data analyst for the Chronic Disease Division here at DC Health. And today I'll be walking you through our data around hypertension in the district with a focus on medication use and condition control. We will also look at trends in hypertension prevalence and self-reported medication use among DC residents at the population level. And then we look at the clinical data from our grantee sites to understand trends in hypertension control among patients receiving care. As you know, hypertension is a critical public health problem and a major risk factor for heart disease, stroke, and kidney disease. Essential hypertension and hypertensive renal disease climbed from the 9th to the 8th leading cause of death in DC between 2022 to 2023, highlighting the urgency of addressing the increasing burden of this chronic condition. Here we see trends over time in the prevalence of self-reported hypertension diagnosis and medication adherence among these individuals, as well as the rate of good hypertension control among patients who visited one of the participating Medinhat's grantee sites. We see rates overall, as well as among population groups by race, ethnicity, and gender. We saw an uptick in the overall prevalence of self-reported hypertension diagnosis overall among DC residents between 2017 to 2023, but a decline in self-reported medication adherence. One pattern that stands out is among Black or African American males who consistently show the highest burden of hypertension prevalence, indicated by the dotted blue line. By 2023, nearly half were living with hypertension. While their medication adherence started relatively high in 2017, it has been declining in recent years. It is interesting to note that despite their comparatively higher medication adherence rate, hypertension control rates for this population group remain consistently lower than the other population groups. Next slide, please. The paradoxical pattern is further reflected geographically when we look across DC wards. According to the American Community Survey, about 81% of residents in wards 7 and 8 are Black African Americans. In 2023, these wards had the highest prevalence of self-reported hypertension, as well as the highest reported rates of antihypertensive medication use in the city. However, despite the higher medication use, we see that hypertension control rates were lower in these wards than in other parts of the district. That is an important finding because it reminds us that having a prescription or even reporting medication use does not always translate into adequate condition control. There may be several reasons for this gap, and this is something we would like your input on. Could it be tied to incorrect use or poor refills? Is that something you can track and monitor on your end at the health system? As we review these data, we would welcome your perspective on what you are seeing in practice, what challenges patients face in taking medications as prescribed, and what support seems to make the biggest difference. Because medication adherence is a modifiable barrier that directly contributes to health outcomes, but it sits within a larger context of patient support, care coordination, trust, education, and access. Next slide, please. On the previous slide, we saw that in 2023, higher reported medication use did not always align with better control. So we then decided to see if control rates improve over time in a meaningful way as patients begin practicing good adherence to their medication. What we see is some improvement across several wards after 2023, which may suggest that medication adherence is having a positive impact on control. But we also see that wards 7 and 8 continue to have some of the lowest control rates across the city. This points us towards the broader questions around correct medication use, continuity of treatment, refill access, affordability, follow-up care, and the social and structural barriers that may affect blood pressure control. To summarize, we see that hypertension remains highly prevalent in the district, and disparities in both medication use and control persist across population groups and wards. They also show that medication use and condition control do not always move in the same direction, which tells us we need to look beyond prescription access alone and better understand the barriers patients face in taking their medication per provider prescription. With that, I'll pass it back to Bonnie.
Thank you, Sonia. If anyone has any questions, please feel free to put it in the chat. We'll do our best to answer in real time, or we can take some answers at the end. And I will pass it on to Corinne.
Thanks, Bonnie. I guess next slide, please. And just a reminder for folks who may not be aware, CRISP-DC offers many different tools to support your care coordination and just your overall workflows with your teams. Today, we're going to be focusing on this last column here, which is Pop Health Analytics. And I'm going to be giving a background on what that is on the next slide. Next slide, please. Thank you. So for Pop Health Analytics, just a bit of a reminder here, we will be doing a demo later on in our portion of the presentation, but wanted to level set for anyone who may be joining us for the first time and hasn't heard of this tool before. So apologies if this is a reminder for folks who have joined us previously, but Pop Health Analytics does offer secure access to comprehensive healthcare data, really aggregate reporting for analytics purposes to empower your organization to enhance care coordination throughout DC. So we leverage our Medicaid claims data to support effective population level and panel level management of this data, driving hopefully better decision making and improving those health outcomes throughout your communities. In terms of the reports themselves, these reports, there's many reports I should mention here, but the suite of reports is designed with a diverse group of our DC HIE users in mind to support analysis and interventions. And what we'll be focusing on today is really tailored for this conversation, but shameless plug that we would be happy to meet with your organizations to do a deep dive on Pop Health or look at any of the other reports that we're not covering today in more detail. All of these analytics are designed to assist users with planning and developing care coordination efforts for different targeted conditions, particular beneficiaries, as well as a variety of other use cases in terms of how best to support your populations. In terms of the utility of these reports, it allows for the analysis of aggregate demographic data, and this data can be stratified and compared and drilled down for different populations based on a variety of factors, including social determinants of health, chronic diseases, patients who may be at high risk, as well as just looking at simply timeframes and other specific classifications that might vary depending on the reports you're looking at. This allows for you to monitor progress on all of the nationally recognized quality measures. And the best part about it, honestly, is the visualization of this data. We have really great reports, which we'll see in our demo later on. But this allows for you to strengthen your communication with your clinical and non-clinical settings to interpret that data effectively and actually act on it. Next slide, please. Something that's unique about Pop Health Analytics, which a lot of our other tools at the HIE don't really have, is kind of a companion app. So this is called Role Manager. You'll hear us talk about that if you ever attend any of our other Pop Health sessions. But the Role Manager application within the HIE is a dedicated tool, sort of a companion to the Pop Health Analytics reporting capabilities that allows a particular point person or a point of contact, Pop Health POC, to control user access for Pop Health Analytics for other members of their team. So the POCs are able to grant access to relevant Pop Health reports for that organization's type to particular end users on their team. And just a side note here that this is really coming from a security standpoint where the POC at an organization would understandably have a better idea on what Bonnie, for example, may need access to for your organization other than myself. So what we do is we credential the POC, and essentially that person is the point person to allow access for the rest of their team as appropriate, as applicable to Pop Health Analytics. Based on the organization's type as defined in our Salesforce, this access is automatically granted to the reports that the organization is provisioned to view. So once you get onboarded with Pop Health, any of those reports that your organization type is quote unquote approved to have access to will automatically take place. So that aspect is quite streamlined. And then what you would do is just work with us to make sure that we credential a point of contact on your team. And then that will be really the go-to person on your team to allow other users to access Pop Health. But again, we're always happy to help. So if you ever have questions about that process, please don't hesitate to reach out to our team. These organization types that will be able to access the reports today, that we're going to be demoing today, are hospitals, FQHCs, payers, and of course, DHCF. Next slide, please. And focusing on the medication adherence reports, this is really the flavor of the demo today. And so these reports we'll be looking at are the hypertension medication adherence report and the statin medication adherence reports. These reports are particularly special because, as we know, non-adherence can worsen some of these chronic conditions and increase those hospitalizations or patients in your population. So being able to really identify these interventions early enables that outreach, education, and overall improves care coordination for your patient populations. So through these reports, providers are really empowered to identify the beneficiaries who may be at risk of that non-adherence to their prescription regimens and then manage those chronic conditions before they get to the point of potentially going to the hospital for an intervention. So allowing you as a provider to view these lists of individuals based on their risk level and identify anyone who may be in that high risk category and really focus your interventions thoughtfully. I believe this is our last slide. I think we can pivot to my colleague Vinay for the demo portion. Perfect. Vinay, I'll hand it to you.
Thank you. Right. I believe I'm supposed to turn that on. Hi everyone, my name is Vinay Balani. I work with H-Metrics. We partner with CRISP-DC to build and maintain the Pop Health Analytics reporting suite. So as part of the demo, just wanted to sort of preempt that with like talking a little bit about the prediction model itself and providing some context around what we've done. So the medication adherence and thing part of this current covered, just to sort of reiterate, medication non-adherence when managing chronic conditions can lead to increased health care utilization and complications. Our idea is to sort of get early intervention in place because again, non-compliance can offset those utilization and costs, and having that early intervention can have improved outcomes. With that said, we developed H-Metrics developed a if you can stay on the slides. Yeah, thank you. H-Metrics developed a prediction model to help identify patients at high risk of being non-adherent to their prescribed treatment regimen. This model was developed specifically for the DC Medicaid population using administrative claims data. And then again, the idea for it is to better inform care management interventions. Next slide, please. So talking a little bit about the medication adherence prediction model itself, it was developed to improve identification of patients who are likely non-adherent to their prescription regimen. And we are looking at it over a year worth of time, right? And it was sort of developed for specific chronic conditions. So in this case, we're looking at statin medication and then hypertension RAS medications. And then so the target of that model was to identify individuals with less than 80% proportion of days covered, and that's the way that we calculate that for those specific prescriptions. And again, that 80% is based on literature suggesting that that's the sort of threshold for most medications. That 80% is also flexible when applied for other medications where that particular proportion of days covered aspect is higher. So again, each model is going to be tailored to the specific regimen. The way that the model was developed was to look at 2 years worth of training data, so years 1 and year 2, and then using that to test the model performance for the year 3. Next slide, please. Yeah. So talking a little bit about the parameters. So as you can see, the inclusion criteria includes all 18-plus-year-old population. Those that are enrolled in Medicaid for the entire PDC period of interest. And again, this is done so that we are capturing everyone who is, sort of staying consistent on their medication. And then also at least 2 prescriptions fills with 90-day supply in the prior 2 years. And so this sort of gives us like identifying patients who are getting chronic disease treatment rather than acute treatment. And then some other variables of interest were looking at PDC across multiple drug categories, prescription drug costs, healthcare utilization cost, inpatient length of stay, ST-WIDGE flags based on Z codes. And so again, giving that broader view of the variables that we're looking at to build the model sort of gave us a better understanding of the patient status. Yeah, thank you. So looking at the model results, we were able to have a strong performance in predicting non-adherence, which is the basis of that. So based on our analysis, we predicted a beneficiary to be non-adherent when beneficiary was actually non-adherent, which is a true positive more than 50% of the times, and predicted beneficiary to be adherent when beneficiary was adherent, which is a true negative almost 75% of the times. And so one of the other factors that came of that was prior adherence is the largest predictor for future adherence. And so again, looking at not just that drug level, but also looking at other drugs that we looked at, that's what we found. Next slide, please. And then the next part of it was to integrate this with Pop Health. So we have a standalone report that will be going into as part of the demo. Another thing that I'll be focusing on is to talk through a little bit about Population Navigator, because that's another tool that can be leveraged to build out those targeted beneficiary lists based on their risk profile, and then view those beneficiaries or like utilization of those beneficiaries across the different reports that are there in Pop Health. So I'll be doing that. And so that's the Population Navigator. And then all of this is for, resources that are available for the care team to be able to target those patients that have high risk of non-adherence. Yep. Next slide, please. Great. So with that, I'm going to switch into the demo real quick. And then if there are any questions that come up as I'm going through anything, feel free to drop them in the chat. And Corinne, if you can help facilitate that, that'd be great. Thank you.
Absolutely. Yeah. And just while you're pulling up the demo, I just want to share that there will be a couple of poll questions that will pop up after the demo. And one of them is free text. So you will need to write in a response. So
thank you.
Just letting everyone know, pay attention.
Yep. And then, yeah, the other thing I just wanted to point out was the demo is from on a demo environment. So all of the data, although it might look like, real PHI, it's not. It's all mass data. But again, just to sort of help understand like how the reports actually look like and how functionally we can sort of move between these reports. So the first one that we're looking at right now is the hypertension medication adherence report that looks at the RAS antagonists. The structure of the report is pretty consistent between statin and hypertension, but again, sort of going into that real quick. Right at the top, we have a description of an idea of like when the claims were refreshed or like what the last paid date is for the claims, and this gives you an understanding of like what the span of it we're looking at when we're looking at that claim. Next, we have 4 different filters available at the top, starting from non-adherence risk category. And so here we have these 4 categories that are also highlighted over here. the higher likelihood of non-adherence. So this is where your population focus comes in, right? Then you have likely adherent, low likelihood of non-adherence, and then medium likelihood of non-adherence. And so likely adherent are the population where they're staying adherent to their sort of prescription regimen. Low likelihood of non-adherence is they have missed some but not a lot. Similarly, like medium, and then high likelihood is where we're predicting that their likelihood of staying adherent to a medication is low, and so that's the high likelihood of non-adherence comes in. We've also sort of categorized them in like these categories, so you can see at like a color level and helps you understand like what that population is. Within the report itself, what you're seeing is at a beneficiary level, what again the different details that get captured. So you can see their first name, last name, gender, date of birth, age, care program that they're part of, zip code that they belong to, if they have hypertension or if they have heart failure as one of their chronic conditions. And so again, this is just staying in line with them being on hypertension medication. Then you also have hypertension medication PDC, which is in the last 1 year, what has their proportions of days covered been like. And that again, like I mentioned earlier, it's one of the prevalent factors when you consider medication non-adherence or prediction of that. So again, it sort of gives you that understanding. So 78% of the times this person has had medication in hand, and that's what it tells you in prior year. And then finally, you have the last column, which is likelihood of hypertension medication non-adherence. So in this case, you can see the first person on this list. And again, when you hover over them, you can sort of see their entire view. But then the first person on this list has 73.59% of non-adherence, and that's pretty high when we look at non-adherence. And that the way that this gets calculated is like I talked about in terms of the prediction model, we're able to sort of calculate this. And so these are the different sort of distributions available. So like high likelihood of non-adherence falls between the 52.63% to 100%, and this is again the characteristic that has been defined for this. Similarly, medium likelihood is between 44 to 52, low likelihood is between 32 and 44, and then likely adherent is 0 to 32. But again, you can sort of scroll down in this list and identify these patients at a beneficiary level. The other, again, you can use these filters as well. So for example, if I only want to look at my high likelihood of non-adherent clients who are part of a specific care program, or who have hypertension as one of their chronic conditions, who also have heart failure as their chronic conditions. And so this helps me like narrow down the population of interest. So that's one way that you can sort of use this report completely. I'll again pause here for any questions from anyone. Feel free to drop them in the chat before I move forward.
Nothing in the chat, Vinay.
Great. So like I talked about, this is one of the reports we have. The next report, very similar in terms of like look and feel and all the details that get captured. But you can see there are like slighter differences between this. So again, looking at the statin medication adherence report, you're looking at the same filters available at the top. The filters slightly change. In this case, we're looking at diabetes and heart failure as the chronic conditions. And so allowing you to filter between that. In the report itself, you're looking at the same detail, where you're looking at the Medicaid ID, first name, last name, all of the different demographic information for the patient, whether they have diabetes or heart failure as one of their chronic conditions. And then you're looking at statin PDC for the prior 1 year. And then finally, you get the likelihood of statin non-adherence. So in this case, you can see that this person, William, has 96% statin non-adherence. And again, that's pretty high. For this one, there are, again, slighter differences between how we're calculating that. So likely adherent is 0 to 55. Low likelihood of non-adherence is 55 to 65. Medium likelihood is 65 to 83. And then high likelihood of non-adherence is actually 83 to 100%. And again, this is based on how we're defining those high likelihood of non-adherence categories, and how many members are part of that report. So I'll pause here to see if there are any questions from anyone. Yeah, then right. But yeah, so if there are no questions, I think this is sort of the first set of reports that we have that look at medication adherence at a beneficiary level. You can get those details directly from this report. Some of the other applications that I was talking about earlier, I can sort of go into that. And so one of the reports of interest here is the Population Navigator tool. And so Population Navigator, I believe everyone should have access to this if you have access to the medication adherence report, is a view where you can look at all of your beneficiaries of interest as a whole. So you can see all of the different details for them. Think of it like as a patient snapshot that you can like see all of these details. And so I'm going to click on this person's name where the patient summary gets pulled up. And so you can see like the patient details right at the top. You can see any chronic conditions that they may have. So in this case, this person has obesity and hyperlipidemia as one of their chronic conditions. You can also look at any PQIs they have, which stands for preventable quality indicators. So any prevention quality indicators that apply to them. Any social needs categories that they're part of. So if they have any, homelessness, or in this case, like homelessness is one of the social needs that they have. So again, you can see those details here as well. Their race and ethnicity information gets captured here. And again, this is how it gets captured in the EHR and available with CRISP. And then finally, you have medication non-adherence. So you can see this person has a medium likelihood of non-adherence to statins. And so that information is then available at a patient level. So this Population Navigator tool sort of gives you that entire view for all of the patients that are part of your panel. And you can see, again, all other details as part of that. So again, looking at some demographic information, whether they are like what the current payer is, any, the DHCF program that they're part of, most recent type of visit or most recent place of visit. And so you can, again, get those details from here. Other sort of aspect that I was sort of alluding to earlier is the ability to create targeted lists. So in this case, for example, if I want to focus on all of my beneficiaries that have specific chronic conditions, right? So let's say heart failure is one of those chronic conditions. So I don't want to look at the 61,000 patients that I'm looking at, but I want to look at the 1924 of those that have heart failure as their chronic condition. And if I want to now look at, the 21 of them who have hypertension, like high likelihood of non-adherence as well. So I would, again, click on that data point. And so these are like filters that I'm adding to create that population. And then again, if I want to keep going, I can do that. But again, staying with the current two that I've selected, I can create something called a roster. And so this roster will specifically be for heart failure, chronic condition, and RAS high likelihood, right? You can name it whatever, and then you would click create roster and review. This pulls up that list together for you, and then you would accept to create that roster. And so that roster is now available. So now what happens is whenever you go into any report within PubHealth, you can then filter your reports for only that population of interest. So again, like if I was to go back to the hypertension medication report that I was looking at, and I click refresh here, I should now see the roster available right at the top. And so when I click that roster, out of those 21 beneficiaries, which of the ones that sort of fall into this group here? And so you can see there are quite a few that come up here, and they all fall under the high likelihood of non-adherence category. You can see only the report only for those that small set of patients. And again, you can do this for other reports. So for example, one of the pieces of interest is the social determinants of health, with that report that looks at, health-related social needs, right? So going into that particular report, you can then filter for this group, and you can view the details here. So I'll quickly do that. And as this loads, Bonnie, if I'm over time, please let me know so I can, quickly wrap up. Okay, perfect. Thank you.
You're good.
Okay. So within this report, as you can see, I have the roster that's already selected. So when I'm looking at this specific report, this report again, just wanted to mention that this is based on Z codes that are collected as part of ADT CCDs that flow into CRISP HIE, or they're collected within the claims itself. So again, looking at this report, you can see that at the top you have filters for start date and end date. This is based on this date of service for those visits. You have chronic condition filters available, DHCF plan that you can filter by, and then social needs category. So again, if you want to further select by a specific category, you can do that. But these are the filters that are by default available within this report. Now, the utilization tab sort of gives you an overview of what you've selected. So out of the 21 beneficiaries that we're looking at as part of my panel, 21 of them, 16 of them are identified here. 8 of them have inpatient admissions. One of those inpatient admissions was an avoidable inpatient admissions. They have also had non-emergent ED use, so about 42% of the times. And then you look at those members that also have a social need. So within the superset of the patients that you're looking at that have the high risk medication flag, 6 of them have 6 members are with a social need. One of them has had an inpatient admission. 0 of them have any. No one has had any avoidable inpatient admission, which is good. And then all of them have, or that 6 of them have had a non-emergent ED visit. And so you can see, why exactly they're going to the ED, and you can get in those details as well within this report. So again, it sort of gives you that overview. Then you sort of go into the prevalence of social needs. So you can see that this is again over time, like how many of them have had a social need, and so you can see like in 2025, all 6 of them have a social need, and so you can get those details. You can also look at distribution of members with a social need. So there are 10 members that don't have any social needs. There are 5 that have 1, and then there is 1 member that has 3 social needs. And again, I'll go into the detail view as well to sort of give you that overview. And then finally, you get to the beneficiary count by DHCF plan. So you can see they belong to MetaHealth, MedStar, and other MCOs that are part of this. Then you have beneficiary count by demographics. So again, the distribution of male, female, and then looking at the different age categories that they belong to. Similarly for race and ethnicity as well, like which are the races and ethnicity values that are captured for them. And then finally, you get to the social needs category. So in this particular case, for the 6 members that we're looking at, they either have financial insecurity, homelessness, or they are part of another category, like a larger category. And then on the right, you're comparing this with all DC Medicaid. So that's the other sort of added advantage, which is now you can see for what does the distribution look like across all DC Medicaid when compared to your own panel. And then clicking on the homelessness category, for example, pulls up like subcategories that are part of homelessness. So again, in this case, like it's a Z590, which is a broader homelessness category, and both of those beneficiaries have that particular Z code associated. Once you click on a specific category, and again, this can apply to any of the other charts that are there, but clicking on a specific tile here, you have the ability to go into the beneficiary level details. Oops. I don't think it wants me to go there. But let's see. There it is. So as you can see here, when you pull up the beneficiary details, you can see, again, the beneficiary information at the top. You can look at whether any of them have had any inpatient visits, any visits that were avoidable potentially, any ER visits, and then any non-emergent ED visits that are part of that. And then you can see if they have had any like social needs. So in this case, like because we selected homelessness as one of the social needs, you can see that both of these members have homelessness indicator, and then one of them also has a financial insecurity and other Z codes as well. So this is the one that has 3 social needs. And then clicking on that beneficiary name pulls up beneficiary details. So you can see again some demographic details for them along with other details. So you can see like that particular patient details get captured, and then these are the race and ethnicity values that are available in the HIE. And so then you can, understand like more about who the beneficiary is. I'll pause here. I know that was a info dump, but if there are any questions, please feel free to drop them in the chat.
I'm not seeing anything in the chat, but I have gotten a few messages in my email already, just
Sure.
requesting access. So just wanted to let folks know that we're working on that on the side.
Thanks, Corinne. And so like I talked about, the application, how you can create rosters and how you can sort of link different reports together. You also have the ability, in a very similar way, to now do the backwards of what we just did, which is you can select a social needs category in Population Navigator, and then you can use that to go to the medication adherence report and view medication adherence for those that have like specific social needs or health related social needs, and so that's the other sort of aspect which is important. So there is like the loop around situation, or like the ability to use one report with the other is built into the tool itself. Yeah, I think if there are no questions, I can pause here and pass this back to you, Bonnie. I do not know how to share this. Oh, stop sharing. There it is. Oh, thank you.
Hello. Okay, so then I know there was questions about like how do I access these reports, or so I think Corinne has just a final slide here.
Thanks, Bonnie. Yeah, just wanted to hold some space for Q&A. I know we've had a couple of folks chime in on the chat. I've gotten a few emails. My email is in the chat, but I'll add it again just for awareness in case anyone would like to follow up after this session. Please do so. We're happy to review anything again in more detail for your team and kind of tailor a training session as it relates to your workflows, or of course, anything else related to Pop Health. I think I'm not, oh, let me see.
Yes,
looks
I
like
launched the question.
Oh, okay. I was like, where did the chat go? Yeah, I think if folks would not mind responding, there's just 2 poll questions. It would be super helpful for us just to have some data on how this session went for you all and how these reports could be leveraged for your workflows. And there's just 2 of them, so greatly appreciate your participation with that. And yeah, I'll be here on until 3 o'clock if there's anything additional for Pop Health. Thanks, Bonnie. Back to you.
Okay. Thank you. Yeah, I think those are staying live. If you can just please make sure to answer those questions. And thank you, Corinne. Thank you, Vinay, for your presentation today. So after we give everyone some time to answer these 2 poll questions, we will also ask to evaluate today's learning collaborative. Those, again, a reminder that where we are in our current cycle or project year of this learning collaborative. Next up is a work plan report out sessions with some of our funded health system partners to report on their current initiatives. And just as a reminder to everyone, this session was recorded and will be available in our Living Well site under Heart Disease and Stroke Prevention webinars. We will follow up with an email and a link to all of this. I am going to now launch the poll questions, poll evaluation questions for everyone. And yeah, thank you all. I think we ended a little early today. And I hope you all had some insightful information. And please reach out to Corinne if you have any questions or about the reports that were reviewed today. I hope also that WebEx wasn't too hard to navigate today. I know that there was some challenges with the mute button.